diffused mortar as a keepsake on his desk. He had 4 children, as I mentioned to you. 2 of them went on to become surgeons. One of them did general surgery residency and is a pediatric surgeon in Roanoke, Virginia. The other one is an orthopedic surgeon who does hand surgery and sports medicine in Pennsylvania. I'm particularly honored that Dr. Harry Dinsmore, Jr., the orthopedic surgeon in Pennsylvania, accepted my invitation to come be with us today for Grand Rounds. Get a little choked up. He's seated right here. Dr. Dinsmore, would you mind standing and accepting a round of applause? And my wife and I met them for dinner last night. They drove 6 hours from Lewistown, Pennsylvania. We had a great time. It was a particularly amazing thing when, after dinner, we went back to the hotel and he brought me the actual mortar, which I encourage you to come up and see. But it's an amazing piece of history. And I initially started researching this story when I was still in the Navy, and I've done a lot. It's not really readily accessible, but I've put together a lot of information. So I really, for me to hold this and take the fuse out of it, and you can still smell the gunpowder in the reservoir. It's really an amazing thing, and I really thank Dr. Dinsmore and his wife Tina for making the trip. And of course, I'd like to dedicate the talk I'm about to give to your dad. So that's all a prelude to the talk, which is removal of unexploded ordnance from patients. So how much time do I have? Oh, okay. Yeah, I knew I wasn't going to get to the hand surgery part, but so this is the talk, okay? I first started reviewing this in the Navy. 9/11 happened. I was coming back to a civilian residency, and it occurred to me that this stuff might not necessarily be the exclusive domain of the combat surgeon. There's starting to be some overlap. One thing that happened in 2004 is a student protesting the Aristide government in Haiti was shot in the back with a 40 millimeter tear gas grenade. It did not explode. He was taken to the hospital, a civilian hospital. He was taken to the operating room. The tear gas grenade exploded in the operating room and necessitated the evacuation not only of the operating rooms, but of the entire hospital. But there's more. That's a picture of a 40 millimeter tear gas grenade. I don't have one. They're not legal in Massachusetts for civilians. I checked. But here's the student. So that's an example of a civilian unexploded ordnance which exploded. Then there was this, and actually this is, I guess the rioting wasn't too bad last night in Boston, but this was back in 2004. Maybe you remember this story. This is Victoria Snellgrove. She was a student who was unfortunately inadvertently killed by riot police after the Yankees lost to the Red Sox for the American League pennant. She took a round to the eye and unfortunately died. Here's a picture of that kind of riot, and here's basically a riot policeman pointing this is probably a pepper round, a paintball round with pepper, which was what she was shot with. But it's also very common for them to use 40 millimeter tear gas grenades, and we don't have riots here, fortunately, but they do happen. So what does the literature say about unexploded ordnance in patients? Well, you have to speak different languages to really appreciate it. And actually, I had a Russian friend translate this second article, which was a Russian article. So there are a few things written about it. I summarized them here for you. It's a rare injury. There's 36 reported cases from World War II through Vietnam. Then there's been 3 additional cases in Afghanistan since 2006. Of the 36, 4 were moribund on arrival. And interestingly enough, the remaining 32 survived removal of the ordnance. There were no injuries to personnel or equipment as the result, and one round, in case you think, oh, well, it didn't go off when it went in the body, it must be a dud. That's not true. One round exploded after removal, but before the bomb squad was able to safely dispose of it. So, and I've got that case for you coming up here. There's been 3 cases in Afghanistan. The deal is that it's a horrible situation. It calls for surgical heroics, but there are certain ways to mitigate risk. There are ways that experts and people who study this recommend. So that's what I'm going to share with you today. So this is just a summary of the data from those articles based on the big graphs are total incidents, and the blue graphs are fatalities. You can see that in the history of this, it's most commonly this weapon, which is a grenade launcher, a Mark 79 40-millimeter grenade launcher. But there's also rocket-propelled grenades, mortars, and then miscellaneous, which is usually incendiary or exploding ammunition. And you can just see these 40-millimeter grenade launchers. This is Seattle in 1999, some kind of riot they were doing in Seattle. Here's Haiti, 2004. This is the same, it kind of looks like a pirate gun. These are ubiquitous. All police departments have these guns with not high explosive rounds, but with tear gas and other rounds for crowd control. Here's a picture of a 40-millimeter launcher in Seattle. You know, perhaps there's a safety on it, but it's being pointed right at these protesters. This is, in the Marine Corps, this was my unit. They mount the 40-millimeter grenade launcher under the M16, and that way you can have a grenade and a rifle in one shot. This was a trip we took to Australia. People always ask me what it was like to be the doctor for a battalion of Marines and get to go to Australia. And I'm not sure how to answer that. But then I was reviewing my old pictures, and I saw this picture, and it was it was really great. In Australia, for some reason, they're really into NASCAR and Formula One. They love fast cars. These girls they're like the Dallas Cowboy cheerleaders of NASCAR, and they invited them. These are our 155-millimeter howitzers that we took there. They invited them to come, entertain us. And the funny thing I always think about this picture, this poor guy who was an Australian actually got in trouble for letting them sit on the guns because his bosses thought it was disrespectful to the gun, which I thought was funny. So what's the deal with fuses? Okay, so fuses are the key to unexploded ordnance. So I'm going to just try to tell you a little bit about fuses and why they're so important. Now, fuses basically they want to do 2 things. They don't want the round to go off before you want it to, and you also want it to reliably go off once you want it to. So did I spell that wrong? It's fuses with a Z, not with an S. Here's an example of why you need fuses, right? Because stuff happens. You don't want a little drop to explode things. Actually, I was watching a documentary on the Enola Gay about the first atom bomb. I think it was a B-29. The bomb was really heavy. They were worried that it was going to crash on takeoff. However, the engineers had not designed any kind of fuse into the atom bomb. Any kind of safety fuse. So one guy made a command decision before they took off that he was going to take out the charges, the starting charges, and because he was worried if it crashed on takeoff that the whole island would be destroyed, which it would. They were flying off an island, off of Japan. And so on the flight to Hiroshima, he, with a screwdriver and these explosives, was reassembling the bomb. It's really an amazing story. So fuse versus fuse. A fuse with an S is really just a wick like you have on your fireworks. And this is actually a fuse from a 40 millimeter grenade. It's a proximity fuse. It's to prevent you from shooting into the ground and killing yourself. It's armed after a certain number of revolutions imparted by the rifling of the round. It's kind of centrifugal armed. They call this a clockwork fuse because it looks like clockwork, or if you take a watch apart. So every single 40 millimeter grenade has this kind of, I think, elaborate fuse for safety. Now, what did John Lyon see when he looked at that X-ray? Well, he kind of, I think, saw the insides of that mortar shell, of this mortar shell, which is amazing. And I think, he went right away to the plunger and how it was partially depressed, and he could kind of see what the insides of that was, and that's why he was so black and white about what the situation was. I'm not going to get into this too much, but there's different kinds of fuses. There's impact fuses, which is the mortar. There's electromagnetic, time, distance, proximity. They all incorporate some kind of safety features into them so that if you're carrying the round and drop it, it doesn't go off. Or if it doesn't go far enough from you, it doesn't go off. The deal as it pertains to surgery is there's a lot of stuff we have in the operating room that can bypass these safety designs, okay? That stuff includes, well, I'll get into it, I was looking at pictures for fuses. It occurred to me that Wile E. Coyote basically used every kind of fuse that there is. So the things that are most likely to be encountered in a patient with unexploded ordnance are mortar, an RPG, or I think the most common by far in the civilian world is 40 millimeter projectiles. Let's just very briefly, the mortar is armed by centrifugal force. After a certain number of revolutions after leaving the launching tube, that nail-like device, that plunger, pops out and is then armed to go off on impact. If Lyons had looked at that X-ray and not seen that plunger stuck out, he probably would have felt more reassured. But as it was, he looked at it and he could tell right away that it was armed and actually partially depressed. Here's a cutaway of common mortar impact fuses, and I just put it next to the 60 millimeter mortar for comparison. RPGs are terrifying. They are set to go, once they are initially armed by the rapid acceleration force, an inertial setback switch arms them. They are designed to go off at the slightest touch because you can't really count on a direct impact. So any kind of obliquity or impact. And one way that they do this is they have a piezoelectric crystal, which is basically like a hair trigger once it's armed. The problem with that is that if you have an impaled RPG, something as minimal as moving the patient, shining sunlight or bright OR lights, or any electrical current like a monopolar cautery can cause it to explode. Here's a cutaway of an RPG. And as you know, RPGs are ubiquitous in Afghanistan, and Iraq. The AK-47 and the RPG are basically make up a lot of what they have there. Finally, the 40 millimeter projectiles. Fortunately, smart people design these to not arm until they've gone 30 meters from you. Again, they're armed, that kind of clockwork fuse, arms by centrifugal force. They're spinning at 3,700 RPM. Those launchers are rifled. I'm not going to read this whole thing, but basically I just want to draw your attention to the last paragraph. Urban engagements often occur at 50 meters or less, and if the round strikes a hard, flat surface with a certain degree of obliquity, up to 25% of impact fuse munitions will not detonate. And And I think that's probably certainly what happened in Haiti, and I think that's the most likely thing to encounter. Here's another case from Vietnam. It's from 1969. It was the 1st Marine Division near Da Nang. A U.S. Marine accidentally shoots another in the thigh with a live 40-millimeter grenade while on this extraction net. And the extraction net was something they dropped into the thick jungle because there's no room for the helicopter to land. The Marines would kind of climb on, maybe clip themselves in, hang on for dear life, and then get carried back. I always wonder, people who haven't, this is not, I love my Marines, I think they were great, but people always say, well, how could that happen? A Marine shot his buddy on the extraction net with a grenade, really? And then I show this picture, but that wasn't mine. They didn't give me any bullets ever. It's like Barney Fife had one bullet, he had to keep it in his pocket. I had none. So here's that X-ray. This is a 40-millimeter grenade in the thigh of this Marine. This is the operating room. This is what a Quonset hut looks like, in case you were wondering. A surgeon named David Lewis, who was 4 days from the end of his tour, removed it under a spinal anesthetic. He, I'm proud to say, is a Rochester native and a graduate of the University of Rochester, like Dr. Stoddard and myself, and Dr. Brooks also, right? He also received the Navy Cross. I corresponded with him several years ago, and he sent me these pictures. He also did an unblock excision. This is not the time to worry about the size of the wound, obviously. Dr. Lewis told me he wasn't really scared. He thought it was going to be routine until he realized that the other surgeons were preparing another operating room for him and had crossed and matched 4 units of blood for him. So he was fine until he saw that. And then he said he was really nervous. He basically thought, everyone else thought he was going to have a catastrophe while he thought it was going to be routine. Fortunately, here's some more pictures he sent me. I just like showing these. China Beach, newspaper articles. He went on to a surgical practice in Virginia and now does kind of volunteer mission work in the Ukraine. Okay, one more case. This one is a rocket. This was actually a friendly fire rocket from a Huey gunship that was an unexploded 3-inch rocket through the knee of a Marine. You can imagine, you know. Here's the X-ray. There's the triage center, the operating room. I mean, it's less than 50 years ago, but it certainly looks like more than that, doesn't it? It's amazing. So who was this guy? He did an amputation with a handsaw. It was Dr. Taft. He had trained under Dr. Zollinger. I'm not sure if he used a regular saw because they didn't have power or because he was actually smart and thinking, but you don't want to use power tools. You either use a giggly saw or a manual saw. I was going to ask the SPD guys if they even could find a manual saw if we asked for one. But so this is the case where afterwards he took the leg/rocket outside to wait for the bomb squad to come take care of it, and then he returned to the operating room to finish kind of cleaning up the wound. And shortly thereafter he heard an explosion, and this is the one, the rocket exploded before the EOD team got to it. He was a complete teetotaler, but afterwards he had a double scotch. He went into solo practice in Washington afterwards. I'm not sure why guys in the military take pictures like this, but it happens to the best of us. This is in the Philippines. That's me on the left, some corpsmen. That is our goat, chained to our ambulance. So things you don't want to do. Obviously, if the patient is moribund on arrival, you're not going to do chest compressions or CPR or defibrillate. Those are all things that you may be programmed to do, but that are really bad ideas. Okay? You don't want to, you also don't want to have anything with a strong radio frequency field, and there's actually a lot of stuff like that in the OR. For instance, blood warmers, probably even the IV pumps, the infusion pumps. Obviously, you can't do an MRI. Radiographs are generally considered safe, and actually the bomb squad, if you don't have radiographs, the bomb squads have portable digital X-ray machines because they can get a lot of information about the ordnance from a plain X-ray. And you should avoid ultrasound or CT. You should avoid electrocautery, avoid power tools, avoid excessive movement, and as Dr. Dinsmore chose to do, the skin prep is not. I mean, at that point, you know, you shouldn't bother. You shouldn't have explosive anesthetic gases or even oxygen if you don't need it. And of course, you should not have unnecessary personnel. The whole, Dr. Dinsmore and John Lyons were there, but otherwise the whole building was evacuated. There's this category that the Army loves to talk about called command decision priorities. What should you do with the rest of the hospital? Well, you really need to cordon off an area with a safe standoff distance. How big that distance is going to be apparent